Department of Microbiology at University of Colorado. And we're having Excel Xfinity problems, but hopefully by Dr. Bob Mason, who's from the Department of Medicine at National Jewish Health. So thank you in advance to the presenters and panelists for their preparation and participation today. We welcome questions from the audience, so post your questions in the chat function. We'll also be looking at the questions to help inform future WebAssembly content for you. So if we don't get to your question today, we'll do our best to answer it in the future. And if you missed our last PEDS Journal Club on the clinical response to coronavirus or our recent pediatric town hall, you can find the links on the Assembly webpage. And with that intro, Dan, I'll turn it over to you to start with a summary of the recent literature.
All right, thanks a lot, Emily, and thanks everyone for having us. My name is Dan Hines. Like Emily said, I'm one of the first-year fellows at the University of Colorado, and I'm going to be taking you through some of the basic science aspects of SARS-CoV-2. Our objectives will be to define some of the genetics and basic virology of the SARS-CoV-2 virus, and then to connect that to some aspects of infectivity and testing, and also some aspects of therapeutics and vaccine development. I don't have any disclosures. So just as a little bit of background, coronaviruses in humans traditionally have caused the common cold. Up to 30% of common colds are caused by the 4 traditional human coronaviruses. 2 are from group alpha and 2 are from group beta. These have a natural reservoir in humans and they're distributed around the world. But over the last 20 years, there have been 3 crossover viruses in the group beta coronavirus family that have caused significant lower respiratory tract infections, starting with SARS in 2002, and then MERS in around 2012, and more recently SARS-CoV-2. SARS-CoV-2 is about 80% similar to the original SARS and about 50% similar to MERS. And we think that it initiated in a bat reservoir and then potentially crossed over to pangolins and then into humans from there. In general, coronaviruses are a group of enveloped, single-stranded, positive sense RNA viruses. They have a very large genome, the largest genome of any RNA virus, which gives them a few unique aspects that we'll touch on in a little bit. They are made up of a lipid bilayer envelope with membrane protein, envelope protein, and spike proteins intermixed in that lipid bilayer. And then inside of the viral particle is nucleocapsid proteins connected to the positive sense RNA genome. To understand what's going on with SARS-CoV-2, I think it's good to have a basic idea of what's going on at a genomic level. So the first 2/3 of the genome is this open reading frame 1, this ORF1, and it's made up of 16 NSP proteins or non-structure proteins. And this ends up being the replication machinery for making the other proteins and pieces of the virus once it's inside of a cell. And the second 1/3 is where you get the structure for the spike protein, the envelope protein, the membrane protein, and then the nucleocapsid that are common features for all coronaviruses. So in practice, this is what a coronavirus will look like. You have your lipid bilayer, which is important because that makes it susceptible to alcohol-based cleaners and soaps. Your spike proteins, which create binding with human cells and cause your infection, and then your other envelope and membrane proteins, and then your nucleocapsid with your RNA inside. So the life cycle of and how it creates replication, your binding takes place with spike protein. It has to be activated, and it's activated by cells on the human, or by proteins on the human side, and then creates binding with ACE2. The membranes then fuse, and the positive sense RNA is released into the cells. Once in the cells, your own ribosomes will make that first 2/3 of the non-structured proteins, which will make up what's called the RNA-dependent RNA polymerase, the RDRP. And that's really the machinery that's going to drive the rest of production. Interestingly, one of the unique features that I talked about was that this, with the size of the genome, there is proofreading function with coronaviruses. So they don't mutate quite as quickly as other RNA-based viruses do. In this next step, you have your positive sense strand and then your RDRP that makes a negative sense strand so that the rest of replication can then take place. And an interesting aspect of this is where we think that remdesivir has its effect with chain termination. And then the final step is your negative sense strand. Your RDRP then makes more positive sense strand viral RNA that can go inside of the particle, or it can make the positive sense strands that become the proteins that then make up the viral particle go into the endoplasmic reticulum, into the Golgi, and then released out into the system. An important aspect of the SARS-CoV-2 virus is how infective it is. And this infectivity is driven by the spike protein and its interactions with the human ACE2 receptor, or the receptor that it uses to get inside of human cells. This process the spike protein has a very strong affinity to ACE2. This binding requires activation, like we briefly talked about before. So proteins on human cells will activate the spike and open it up into two subunits, the S1 and the S2 subunits. And the S1 subunit is where the receptor binding domain is to actually bind to ACE2. In SARS initially in 2002, the spike protein activation relied on TMP-RSS2, or a serine protease that's found across many different cell types. But notably with SARS-CoV-2, there's an additional furin cleavage site, which is another protein that's ubiquitously found throughout the body, probably being the reason that it has greater infectivity. It has an additional way of being activated and entering into cells. Potentially this could be a therapeutic target. However, it's not clear what blocking these two pathways would do to other essential cell functions. The other side of the infection process is the human ACE2 receptor, the human ACE2 protein. This is a protein that's expressed throughout the body, but notably is highly expressed in the apical side of well-differentiated ciliated cells in the respiratory tract, and then also in type 2 alveolar cells in the alveoli. So its normal function is to be a counterbalance to the pro-inflammatory parts of the RAS pathway. So you can see here angiotensin 2 is cleaved into angiotensin 1 to 7 by ACE2, and angiotensin 1 to 7 has anti-inflammatory effects, anti-fibrotic effects, and vasodilatory effects inside of the lung. And you can see some other cytokines that have become more well-known with COVID infections. Human ACE2 receptor expression and its relationship to COVID during an infection is under investigation. We think that ACE2 may have a protective effect in virus-induced lung injuries, which has been seen in some animal models. And we also think that SARS-CoV-2 likely downregulates ACE2 after it creates an infection inside of cells. How this exactly could play out in different therapeutics is currently under investigation. And then the interactions of ACE inhibitors, ARBs, ibuprofen, and even nicotine may have different effects on ACE2 expression. And these things are all also under investigation. And there's a nice review in the New England Journal from last month that goes over some of the high points of this pathway. After an infection takes place, your body is going to produce antibodies. Your immune system will produce antibodies. And most importantly, the level at which antibodies are produced that would provide protection isn't known. So we do know that SARS-CoV-2 from a study in China of patients who were known to be positive through PCR and were hospitalized had antibodies, IgG antibodies by 19 days post-infection. Most of these target the spike protein, which is the driver of infectivity. But the rest of our knowledge we're still building, and we take a lot from our experiences with SARS and MERS. So we know that from SARS, some patients had undetectable antibody levels 3 years post-infection. We know that with MERS, IgG levels were tapering at 1 year post-infection. And we know that antibody response in MERS was proportional to the level of illness. So mild illnesses had less IgG response than severe illnesses. And how this is going to play in to our next topic will be very interesting. And our next topic is just to briefly touch on vaccine development. So our goal with a vaccine is to replicate our body's immune response with antibodies without having a severe infection. So the big questions that come up with this are, is the immune response robust enough to confer immunity when we introduce a vaccine? And how long will that immunity last? Can this vaccine be made on a large scale, and is it safe? And these questions are all things that typically have taken 10 to 15 years to develop on a large scale, but we're trying to condense down into a 1 to 2 year process. And the big take home from this slide is just that despite only having had this virus around for several months, we're at a very advanced state for vaccines with still a long way to go. So there are many companies and organizations pursuing different vaccine types. And I think there's a lot of potential and excitement around the DNA and RNA vaccines that are being pursued, but there are many other types that are also being pursued. So in conclusion, the open reading frame 1, or that first 2/3 of the genome, creates the machinery to produce the structure proteins and the RNA that are necessary for further viral replication. It's a high fidelity process, meaning that there is some proofreading. So mutations in coronaviruses tend to be less frequent than other RNA viruses. And this replication process is the target for remdesivir. The spike protein requires activation prior to binding to ACE2, and it has a very high affinity and therefore is very highly infective, creating the infectivity of the virus. ACE2 may have a role in the inflammatory process after infection, but that's under investigation now. And antibody production against spike protein and recreating that inflammatory response are the main keys to vaccine development. And now I'm going to turn it over to my co-fellow Mafan to talk about some of the clinical aspects of COVID-19.
Great, thanks, Dan. All right, so my name is Mafan. I'm one of the first-year pediatric pulmonology fellows here at Children's Hospital Colorado. And today I'm going to be talking to you about the clinical presentation and course of COVID-19 with some comparisons to adults. We're also going to talk about treatments that are under investigation, highlighting some clinical trials, and also talking about studies for the future. So this schematic shows an overall timeline of coronavirus disease. And typically from the onset of symptoms to hospital admission has been on average about 7 days. From there, patients may have progression of symptoms, including shortness of breath and an ARDS-like illness, requiring ultimately ICU admission in severe and critical conditions. And in pediatrics, like I'll highlight in the presentation today, you may not see this full progression of disease. They have less severe respiratory symptoms and so may not have this ARDS-like illness or ICU admission. Overall, looking at pediatric US COVID-19 cases, in the US, they represent about 1.7% of cases. Like I've mentioned, pediatric patients are less likely to be hospitalized. And so in this particular analysis, they had about 5.7% patients that were hospitalized compared to adults, which had 10% that were hospitalized. Interestingly, in this analysis, up to 68% of patients in pediatrics did not have fever, cough, or shortness of breath, and up to 1.3% were asymptomatic. You do still see a male predominance with about 57% being male. In this schematic on the left, the black bars represent patients that are not hospitalized. The medium blue represents hospitalized patients, and the light blue represents ICU admissions. I wanted to highlight in the age group less than 1, about 62% of those patients in that age group were hospitalized, and that's greater than any of the other age groups in pediatrics. Additionally, highlighting in ages 15 to 17, they represented about a third of cases so far in the US. To date, we have 10 reported deaths in patients up to 15 years old and 48 reported deaths in patients 15 to 25 years old. In this slide, I wanted to highlight the difference in symptom presentation for pediatric and adult patients. In this study, adults were shown to have occurrence of fever in about 70%, and some studies report up to 80%. In this particular analysis, pediatric patients had fever in about 55% of patients, but as we're getting more numbers, that number is even dropping to less than 50. And you can see that also is similar for cough and other syndromes that are shown here. Thinking about comorbidities that are present in patients in the US, the green bars here represent pediatric patients and the blue bars represent adult patients. I wanted to highlight a couple things looking at the first group up here, seeing that asthma was present in about 18% of pediatric patients. Interestingly enough, in this analysis, though the numbers were really small, there were no reported patients with chronic lung disease, and that might be because they're represented in other areas, which we'll talk about shortly. Excuse me. I also wanted to highlight obesity being present in about 28% of pediatric patients, and we know that obesity is pro-inflammatory. And in this other group, which was present in about 18% of pediatric patients, that represented patients with technology dependence, including trach or vent dependence, G-tube dependence, and even wheelchair dependence. So that might capture some of the patients with chronic lung disease. Thinking about laboratory findings in COVID-19, the pediatric presentations are significantly different than the adult presentations. In adults, they're noted to have severe hematologic abnormalities, whereas most children have normal leukocyte counts. Additionally, you can see that adults can have significant inflammatory markers that are elevated, in about CRP being high in 61% of adults, compared to 13.6% of pediatrics. Adults can also have significantly elevated D-dimer levels, and that can contribute to a coagulopathy, and that's less likely in pediatrics. Pediatric patients do have a higher incidence of concurrent viral infections such as RSV and influenza. This data is in adults, but looking at things that lab findings that are associated with death. So on the left, with orange being non-survivors at the top, you can see that leukocytosis was associated with death in adults, and on the right, neutrophilia was associated with death in adults as well. This is additional adult information. Looking at the left schematic, you can see that lymphopenia was worse in patients that were non-survivors in orange at the bottom. I briefly mentioned D-dimer being elevated in adults, and this is really seen in pediatrics, but here on the schematic on the right, you can see that non-survivors at the top in red had much higher levels of D-dimers. In terms of thinking about the lung pathology, we think that this is related to a vascular-based injury that results in microvascular pulmonary thrombosis that leads to an atypical ARDS-like disease. Dan already talked to you about how the virus enters the cell through the ACE2 receptor, and this particular schematic highlights IL-6, which we are learning is important in the lung pathology. And due to high levels of IL-6, you do have significant pulmonary vasodilation that can result in several phenotypes of lung disease. I think the most common is an L type, which accounts for 70% of cases, where the lungs are partially flooded. You have partial flooding of the airspace with low VQ units, and they have low recruitability of their lung tissue. There is another phenotype known as the H phenotype, accounting for about 30% of cases in which they have more drowned airspace disease, massive shunting, and on imaging are more heterogeneous. And these patients may be more recruitable and thus might respond more to things such as proning. In this particular study, patients were analyzed to look at their baseline cytokines, and looking at patients who ended up intubated and had severe disease, they were noted to have high IL-6 and high interferon. So again, pointing to the schematic that I talked about previously, we're learning that IL-6 is really an important marker for severe respiratory disease in adults. In pediatrics, there is an emerging clinical syndrome known as pediatric multi-system inflammatory syndrome, in which we're seeing patients presenting with the Kawasaki-like illness or toxic shock-like syndrome. In this particular case report, there was a 6-month-old who presented with persistent fever and mild respiratory symptoms. She did progress to have a Kawasaki-like illness, but I wanted to highlight that she remained cough-free and had minimal respiratory symptoms during the course of illness. The labs were like you would expect, with a significant inflammatory response with leukocytosis and elevated inflammatory markers. This patient had a normal echo and was ultimately treated with IVIG and high-dose aspirin with resolution of symptoms. As we're learning more about the role of IL-1 and IL-6 in COVID-19, there might be a role for these therapies in the future in terms of treating PIMS. Overall, for respiratory support in COVID-19, we do have poor oxygenation, and so you focus on using nasal cannula and high flow to provide adequate oxygen. We try to avoid non-invasive ventilation due to adult studies that show a high failure rate with patients requiring intubation, and also because we consider this to be aerosol generating. With mechanical ventilation, we use lung protective techniques with low tidal volumes, recognizing that you may have really significant PEEP requirements, especially in the L type that I mentioned before that have low lung recruitability. Proning is important, and using this early on especially might be more important for patients with the H type, and also considering things such as INO. Overall, there are many treatments that are under investigation, and I've highlighted some of them here. We're not going to talk about all of them today, but I wanted to highlight that JAK1, IL-1, and NLRP3 are upstream of IL-6, which we've talked about being really important in this pulmonology pathology. I wanted to highlight just a couple clinical trials. In this particular study, this is in adults looking at 21 patients that received tocilizumab, which is an IL-6 blocker. And you can see in the schematic on the left, they had significantly decreased and ultimately normalized CRP levels. They had improved fever. And additionally, on the bottom, you can see their oxygen requirements decreased and remained stable, and their SpO2 increased and remained stable over time. Again, we still need more studies and controlled studies to really understand more how to use these treatments. I also wanted to highlight the study that was recently released on remdesivir. And this study showed that there was clinical improvement, again in adults, with no mortality benefit in severe COVID-19. This study had no control groups, and patients were enrolled in the study via Gilead, who is the drug company. But overall, looking at clinical outcomes, we saw that there was improved oxygenation in 68% of patients, 56% of intubated patients were extubated, and ultimately 47% of patients were discharged. It is important to note that 60% of patients had adverse effects, and up to 23% had serious adverse effects, which included multi-system organ failure. So again, we do need controlled studies and more studies looking at safety of this medication. I wanted to end on just discussing briefly why pediatric populations may be relatively spared. So we don't really have a true understanding, but there are many theories. We know that ACE2 receptors are the way that SARS-CoV-2 enters the cell, and pediatric patients tend to have decreased binding ability compared to adults. Additionally, we think that kids have higher viral immunity due to recurrent respiratory infections compared to adults. And finally, as we're understanding the role of IL-6, we do know that elderly patients have higher levels at baseline, and so that might contribute to the severity of disease. In conclusion, I wanted to highlight that children do have less severe respiratory disease and may additionally be asymptomatic carriers. As we're learning more about COVID-19, we're finding that endothelial injury and microvascular thrombosis plays a significant role in the pathology. And we do need more information on emerging symptoms such as PIMS. We do need randomized controlled trials to determine treatment targets and safety. And overall in pediatrics, thinking about the impacts of COVID-19 restrictions on overall care. And that's the end of my presentation.
Can you hear me?
Now we can.
Okay, sorry.
We can't hear you.
Okay, I actually could not hear you for some reason, but I guess I will start. Okay. Do you see my screen? Okay.
We can't hear you.
Okay. So
Please
I
try to
guess-
speak, but we can't hear you at all, Emily.
oh, okay. Can you hear me? This is Elena.
Elena, I can hear you.
Oh,
Can you
Emily,
hear me?
now we can hear you. Okay.
There's Emily.
Okay.
Maybe.
Okay, I just said, thanks to Dan and Mafan, they really covered a whole amount of information in that short time. So that was fabulous. Can we do a mic check with Bob Mason? Can you hear us, Bob? Can you talk? Okay, we'll see if we can get Bob on. Elena Shea is from the section of immunology, and I asked her to speak a little more on the inflammatory response and tell us what we need to know. One of the things Elena and I have been talking about is really that the whole panel has been talking about is that a lot of the drugs just treat one pathway, and obviously COVID is much more complicated than that. So go ahead, Elena. Sorry about that technical challenge.
No problem. Thanks, Emily. And please let me know in the middle if you can't hear me for some reason. But I'm going to just touch upon a couple of things in terms of the immunological response in COVID. As you all know, the immune system is a system, so there are many different cell types at play. If we think about the normal trajectory to an infection, and I think this graph here was from a recent grant rounds given here at the University of Colorado, is that for any given infection, you normally would expect that if you control the virus or bacteria in the setting of a normal functioning immune system, you have a surge in inflammatory response, which you should, and then eventually you hit a recovery phase. In the setting of whether you're immunocompetent and can control the virus, or you're immunodeficient, so you start falling more in this category of immune dysfunction, or if for some reason you may experience from an immune standpoint cell exhaustion, you actually cannot control the infection in the interim, and then you do not hit the recovery phase. So as you can see here where the x-axis, this is actually number of days, timing of when the response comes off and should then retrieve is very important. I like to say that the immune system is like a very efficient army. It is designed to fight even if it's being inefficient. And that is essentially what we see in the hyperinflammatory state, where the immune system cannot eradicate the infection, yet it continues fighting. So what does that mean in the context of COVID and in the pediatric population? So let's see if I can flip to the next slide. We already heard about the type 1 interferon response in the context of a viral infection. So if you ignore for a second on these red comments, which is how the virus actually has learned to evade the immune system, when the virus enters into the cell, there are specific receptors, of course, the ACE2 receptor, but other pattern recognition receptors that in innate immune cells are present to be present at the scene and fight the virus. And this is where you have a type 1 interferon response. So we need this to be able to have an effective viral response. The virus has also developed different mechanisms, coronavirus in general, as to how to evade parts of this response. And that's where all these red comments on the side come on, where you have specific proteins in the virus that are designed to inhibit these pathways and therefore not make an efficient type 1 interferon response. Now, you also have heard that hyperinflammatory response can be related to too much type 1 interferon and also too much engagement of IL-6 and IL-8. So how is it that you need this response to control the virus, but yet if you have too much, you then actually enter a non-healthy state of a hyperinflammatory response? We don't fully understand that at this time as to what determines whether a person will effectively control infection and have, quote, just the right amount of type 1 interferon to control, or will go overboard and produce too much type 1 interferon. So this is a heavy area of investigation right now. We do know that from monogenic defects, inborn errors of immunity, the people who have defects that disable them from having an effective type 1 interferon response are more susceptible to viruses. We also know that people with monogenic disorders in this pathway, if you have this pathway on too much, and that's a type 1 interferonopathy, you also experience immune infection susceptibility, plus you also display a hyperinflammatory state similar to what we see in patients with COVID infection. So if you naturally are born with a defect that makes you make too much type 1 interferon, the clinical symptoms you see in those children is very much like the PIMS description that you just heard, the pediatric inflammatory multisystem response, where you can get thromboembolic events, you can get high fevers, high CRPs, septic shock, all of that. So enough similarities there to understand that this is a key pathway in what we see in the pediatric population. Again, details I think to be fully understood. And the last thing I want to end on is you have also heard discussions about IL-6 and IL-1. I realize this is a complex slide, but I want to focus your attention on one, the different types of immune cells that are involved in this response. You have dendritic cells, and these are the major producers of type 1 interferon. So this is essentially the cell that I showed on the slide before, making type 1 interferon. You have T cells, B cells, NK cells that are also trying to fight this infection, as well as monocytes, which are one of the main producers of these cytokines. And the main message I want to communicate here is that, again, the immune system is a system. All the different players work together. And if you have an imbalance of any one of these specific arms, you may end up making more of a specific type of cytokine. And we have to walk the balance of blocking the cytokines and shutting off the immune system where you're in a hyperinflammatory state, but being careful not to do it too early on in the infection. Otherwise, you actually do not have an effective immune response to the infection. And I will end on that.
That was great. That's exactly what I wanted to know. All the cells are related. We're going to go to Livia. Can you tie in the coagulopathy? So those of you that don't know, Livia and Carl study inhalational injury and airway injury. Livia is going to tell us a little bit later about the clinical trials she's been involved with, but I wanted to relate the immune response and the inflammation to the coagulopathy.
Yeah, definitely. Thank you, and thanks for having me be involved in this great journal club. So I wanted to talk about coagulation more extensively for the next 3 minutes. And just as a little review with COVID-19, in adults, 15% of those patients appear to have type 1 respiratory failure, which is hypoxemic-related respiratory failure. And a third of those go into the ICU for an ARDS type of injury. It looks like they have multisystemic injury, lots of abnormal coagulation labs, and they seem to have been correlated with a poor prognosis as well. As we have heard before from Dan, this virus is very closely related to SARS-CoV-1 and MERS-CoV, and both of those have shown an increased procoagulable state, which has conferred a worse survival in those patients who got it. Now, in COVID-19 specifically, we've seen extreme procoagulable state in frequent loss of critical care lines, hemofiltration circuits in a lot of patients, and these are all adults with acute kidney injury. There's also frequent venous thromboembolisms, or VTEs. And there have been a few autopsy findings that have been reported early on. The first autopsy finding came out from China, and it was showing fibrin deposition and microthrombi in the lungs, and also in many of the other organs as well. And this is very similar to what the MERS and the SARS-1 used to show. More recently, on May 6th, we had a new publication in the Annals of Internal Medicine from Germany showing 12 autopsy results, as well as postmortem CTs in these patients. And what it showed is 4 of the patients had pulmonary emboli, 4 of the patients had bronchopneumonia with no ARDS, and yet they were diagnosed as ARDS previously. All of them had microvascular thrombosis in the pulmonary circuit on histology. And they, in this particular set of patients, they did not see any thrombi in any of the other organs. So that was a very interesting and new finding, hot off the press. In addition, we have also had some publications on multiple pulmonary emboli in these patients in COVID, cerebral infarctions, DVTs in Wuhan. From a Wuhan retrospective study, they found 25% of the patients in the ICU had a deep venous thrombosis. In another study from the Dutch group, 184 patients, 31% had thromboembolic events. So it is pretty high in a number of patients. We've seen them in autopsies of patients who die. So it's very important to look at. Of course, the risk for thromboembolic state in ARDS in general has been shown to be mechanical ventilation, particularly increased PEEP in patients can confer them to be more likely to have thrombotic events. So that's something to remember as we think about how to treat these patients. Presence of vascular lines also increases thromboembolic states. Hypoxia does as well, and sepsis. And all of these are present in COVID. So the question is, what we see in these COVID-19, is that ARDS, or is it pulmonary emboli or microvascular thrombosis? They both present very similarly. They both have hypoxic type 1 respiratory failure, but the treatments are different. With pulmonary emboli, you want to anticoagulate, use thrombolysis, embolectomy, IVC filters. But with ARDS, you would do the high PEEP, low tidal volume, volume restriction, and all of those can predispose them to an increased coagulable state. Now, where is this coagulability coming from? And there are a lot of theories about this, but there is something called an immunothrombosis model where inflammation and coagulation are linked. For example, fibrin, which is a portion of the clot, obviously, it's been theorized to be an effector arm of the immune system by trapping invading pathogens. And it's a hallmark of diffuse alveolar disease and acute lung injury as well. Inflammatory mediators increase local tissue factor expression, which is a clot propagator. The fibrin matrix facilitates inflammatory cell invasion and alveoli into the alveoli, like macrophages. And macrophages will contribute to D-dimer formation, which we have known to be extremely high in COVID-19 patients. Now, all of this is in adults. In pediatrics, interestingly, we have not really seen a hypercoagulable state, but in pediatrics, we have not seen the same type of disease. We talked about the Kawasaki-like disease that's been popping up more in children, and it might be similar, but it seems to be somewhat different too. So it remains to be seen if we have a procoagulant state in the children. Either way, it is something to focus on in COVID-19 and make sure that we properly treat them either with anticoagulant or fibrinolytics in patients who are procoagulant.
Livia, there was a question from the audience. Do we know if the proning is helpful in the ARDS-like patients or the patients with microemboli, or we don't know which patients it works for yet?
We know that proning works the best in all the patients, no matter which type you're talking about. L type, H type is a theory, and we're trying to categorize as much as we can, but we do know that if you have some sort of microvascular thrombosis, they will occur in the most dependent lobes. So if you prone those patients, then you will improve VQ matching, even in patients who have thrombosis in their lungs. Or consolidated, it's the same story. You're just improving VQ matching. It works for both.
Okay. Can we try another mic check with Bob? And
I think, can you hear me?
yes, we can.
Well, that's very.
So Bob spent his career studying coronavirus. So I asked him to speak a little bit what we've learned from SARS, how we can, how kind of to put it all together, and the ACE2, and how important is that for us to know about.
Okay, so let me start basically about there are significant differences, and I think I would like to go through about different anatomic sites and contrast the two. So let me start. So in SARS, we didn't focus on the asymptomatic carrier, and we didn't focus because people had fever, and the temperature checks were very effective for that particular disease. But now we have this asymptomatic carrier, and the question is, well, where's the virus when they're asymptomatic? And the answer is we don't absolutely know, but it's most likely it's in the nose. So the conjunctiva and the nose is the ciliated cells as well as some mucus containing cells. And I think the research question on that would be, we really need to know more about the innate immune system in the nose. In other words, the respiratory viruses obviously propagate in the nose, and you can be very asymptomatic. And in terms of this disease, you asked the question, well, maybe early on we should increase the innate immune response to prevent the disease from progressing down the airway towards the distal lung. So I would say the focus on the nose is different in this disease than SARS. In terms of the conducting airways, the pseudostratified bronchial epithelium, the disease will be the same. That is, it'll affect mostly ciliated cells and few mucus cells and probably no basal cells. This is based on what was done with SARS. You will read in people that do RNA sequencing on single cell analysis that there is ACE2 in a lot of cells, but if you look at the numbers, it's extremely low. And there may be a few basal cells that have some ACE2, but basically, if you look at the histology from the primate, they're not infected, and from looking at SARS, they're not infected. What is new is the issue of the club cell. So the club cell was probably infected with SARS, but nobody really looked at it. So in the human, the club cell is in the very distal part of the respiratory bronchioles. And that's different than in the mouse, where it's all the way up to the trachea, or the hamster, where it's basically mostly in the distal lung, but then goes all the way up to the trachea. So the club cell is involved, and I think that you'll find out there'll be a lot of a very small, if you want, bronchiolar disease with this that has been underappreciated. And club cells have not been isolated much since the 1980s, but they're not too difficult to isolate. And I think this will be a future area for research. When we move into the alveoli, I think it's going to be similar to SARS. That is, the type 2 cells will be the ones that are infected. And if you want infection in type 2 cells, you have to make them very differentiated. My bias on this is that you need, for the ciliated cells, you need the cilia, and for type 2 cells, you need the microvilli in order to get effective infection. But if you take type 2 cells and have them poorly differentiated, they won't be very infected. They weren't with SARS, and probably not with SARS-2. In terms of the type 1 cell, type 1 cells were not thought to be infected with SARS, but nobody really looked at it very well. In the primate, with the current virus, you can see infection in type 1 cells. But if you look closely at the images, you'll see there's a type 2 cell in the same image. And I think it's going to be more cell-to-cell spread than directly infection of the type 1 cells, but we'll just have to wait and see. In terms of the innate immune system in the distal lung, I'll just bring up that it's incredibly complex. And there have been a lot of systems biology studies in terms of virus infections, both with SARS, but also with influenza. And the cell that gets infected, the epithelial cell, makes a ton of different cytokines. And then it affects bystander cells, either another type 2 cell or macrophages or others that put out cytokines. And then it recruits a whole group of other cells that make a ton of cytokines. So I think working on just one factor in it may be effective, but there may be some strategies of trying to dampen down multiple effectors in the innate immune system for the cytokine storm. The last part I want to emphasize is, that people may not know about it, is that the hamster is an excellent model for this disease. When they try to infect different animals with this particular virus, it was obviously the human and the primate and the hamster were the ones that developed infections without treating the animal to make them immunodeficient. Mice and rats were not infected as in the studies that I've read early on. So I think the hamster will become a model system for people to look at. In both the hamster and the primate, these are non-lethal infections. Although in the hamster, if you look at the paper, you'll see that it's a pretty diffuse pulmonary infection. So to summarize, I think the differences will be in the nose. This is important. The club cell is different. And then the animal models are different. And I really like the idea of looking at the primate, although it's very difficult, but you can look at the effect of therapy. You can look at the effect of age. And you can also try to sort out this issue of this alveolar flooding early on with this VQ match and what's the vascular part. One minor issue, it's not really a substantive difference, but I don't think endothelial cells get directly infected. I think they're clearly damaged, and it's clearly part of the thing. It's maybe just a somatic difference. But I think the issue is we'd like to see really a documented infection with virus being produced in the cell for what we usually call infection. But there's no question the endothelium is severely damaged in this disease. So I think I'll stop at this point and just respond to questions.
And we have two
Great, I might
questions
have
from the
Carl.
audience.
Oh, good, let's do that.
So the first one, Bob, for you is, in primary ciliary dyskinesia infections, do you think that this is going to make the infection look different because of ciliary dysfunction?
I just think it'll make it much worse, and that the chance of propagating down to the alveoli will be greater. I mean, I think the issue is the mucociliary escalator basically tries to keep the infection heading towards the mouth. And if you impair that either with more infection or with ciliary dyskinesia, it'll be worse. So I would say that in terms of the binding to the ACE on the cilia, I think it'll be probably the same. But I obviously don't know.
And there was another question that was similar with cystic fibrosis.
Yeah, I mean, I think the issue is anything that'll impair clearance, it's more likely that the infection will head deep down into the lungs. I would think that it just basically would be a huge risk factor for more serious disease.
And Bob, could you comment on how this virus compares to the prior coronaviruses in regard to possible duration of immunity after infection?
Yeah, the answer is I don't know that specifically, but the issue is that most coronaviruses are obviously circulate in the system like 229E, but don't cause really serious disease. And I honestly don't know the immune system, how much damage you have to have an effective immunologic response. It seems to me that diseases which basically start with a good, strong innate immune system and then get an acquired immune system will get antibodies and will be protected. My bias is this, that we will have antibodies that'll last a year or so or more that will be protective, but obviously I have no primary data and am not an expert in this area. The other thing I would just out of interest is there's another circulating coronavirus that may be on your screen called NL63. And NL63, you'll be happy to know, uses the ACE2 receptor and obviously doesn't cause this type of disease. But it's the receptor binding is a little more complicated.
And Bob, one more question for you. Could you comment on the ACE inhibitors and if they have any potential protective effect in your mind?
It's very controversial. So the issue is, and people have looked at ACE inhibitors and does it have anything to change the disease to make it better or worse? The answer to that, and there was one in the American Journal of Cardiology, it basically said there was no effect. So I think it's highly unlikely. To me, ACE2 is a binding site for the virus, and that the enzymatic activity of ACE2 is probably not involved, but that's controversial. Certainly, ACE2 is thought to basically be a protective factor for ARDS, and I think there just needs to be more studies. But in terms of people that are on ACE inhibitors and so forth for treatment of hypertensive, they're supposed to be continued on these medicines, and it's not supposed to alter the clinical course.
Carl, can you pop in and kind of tie it all together for us? What are your thoughts on?
I was going to talk about animal models, and I could just say Bob Mason, what he said, but I'll take it a little farther than that. So all of our animal models are sublethal, and none of the models, the animals become ventilator dependent either. So the most viable animal models are, as Bob said, the hamster, the ferrets, and the non-human primates. The hamster gets good viral replication in both the upper and lower airways, and it peaks at like 2 to 3 days, and then it clears. And the maximum consolidation in pneumonia in that animal is 6 to 7 days out after inoculation. So it's interesting that the virus has been gone for a while, and the disease still propagates. There's few reagents for the hamster, obviously, but there are already some transgenics coming with the hamster. There's a STAT2 knockout that's already available. And the hamsters show spread from one to the next when they're caged together. Ferrets are a little bit more hard to handle, and they have more upper respiratory than lower respiratory propagation of virus. They get sick, they have fever and inactivity, and they are good models for both direct and indirect aerosol transmission. And since they're a larger animal, you can get multiple samples on different days from the animals. But again, like the hamster, there's few species-specific reagents. And then in terms of the primates, the old world monkeys are better than the new world monkeys. So rhesus and African green monkey are the ones that are most, they show the most disease, whereas the cynomolgus monkey shows less, and the least is the common marmoset. And they have an age-dependent disease severity situation, kind of like what we have in humans. And the rhesus has a lot of those kind of features. We know that they have mild to moderate respiratory disease. They, like the ferret, they have more upper respiratory than lower respiratory tract virus. And they have persistent shedding for quite a while in both the fecal samples and the nasal samples. So they're a good model to study for the shedding issues. And in terms of lung disease, they have pulmonary edema, hyaline membrane formation, interstitial pneumonia, and multifocal consolidation. Again, suggesting the vascular spread, perhaps. And I think the point's probably already been made that ACE2 amino acid homology with the human protein is what confers infection susceptibility. So I'll cut it off there.
Well, we're getting close to the end of the hour. I wanted to thank everyone. I'm still going to ask another question about clinical trials, but I know some of you need to leave. And we will see you at the assembly meeting next week. But I wanted to, if you are able to stick on with us for just a few minutes, Livia's been involved in the clinical trials of TPA and COVID. And as you know, we are all crazy busy, so I don't know how you could get a group of scientists to organize anything quickly, but Livia's going to talk about that, and Lena will briefly talk about some of the international collaborations in immunology.
Yeah, thank you. Can everyone hear me?
Yeah.
Okay, great. So I wanted to quickly talk about the systemic TPA administration for the COVID-19 severe ARDS-like syndrome. It's a multi-center collaboration between Harvard, MIT, Denver Health, University of Colorado, and New York City Northwell. Everybody gets really fired up when, as physicians as we are, to try to do something new and something that might work. We have done some off-label trials with TPA in patients in New York City in mid-March, when the first patients started to arrive. And there were some improvement in P2F ratio in patients that were given IV systemic TPA. We also have tried airway TPA, airway delivered TPA to some of the patients, and that also had some effect, but because of risk of aerosolization, that was a lot more pushback, and continues to be a lot of pushback to try to continue to perform. So systemic TPA it's a safer thing to do at the moment, and it has shown some efficacy, which we have published recently on. The systemic TPA for acute respiratory failure is what it's called for COVID-19 or STAR trial. It is an adaptive design phase 2 clinical trial. And we will be comparing the pulmonary embolism dose of TPA versus a lower dose TPA, 50 milligram versus 100 milligram infusion over 2 hours with therapeutic heparin afterwards. Now, it's questionable if heparin is the way to go or more direct thrombin inhibitors might be better. We are not sure. Very difficult to get IRB protocols in place very quickly. IRB protocols take months and months. Here we are on a timeline that's much faster. So we just got, and this was a month in doing to get an IRB protocol in place in University of Colorado. It's still pending at Harvard and it's still in process in New York City. So here we are 4 weeks out of the trial that was funded by the drug company Genentech, and we are still attempting to recruit our first patients. That's where we are with that.
Okay, well, maybe we'll have you back with more data. Thank you. Elena,
Yeah, I can talk about the studies ongoing on campus and sort of relationships with other consortia. So on campus here, both at the University of Colorado Adult Hospital as well as Children's Hospital Colorado, there is currently an approved IRB for consenting inpatients into studies. So anybody that is COVID positive and admitted for hospitalization can be enrolled into study. We're aiming to consent as many as possible. We also understand that in this setting, we may have to waive consent in some circumstances. For example, if the patient is intubated and cannot consent herself or himself, in that case, they go into a different arm of study, which is a waiver of consent. In both arms, we are collecting clinical data as extracted by their medical chart, coming into REDCap at Compass, as well as biological specimens. That's usually a research blood draw that is tacked on to a clinical blood draw to be able to isolate and store for future studies, plasma, serum, peripheral blood mononuclear cells, RNA, DNA. So that is a campus-wide biobanking protocol. Then there will be ability for investigators to request such samples under a governance structure, provided there's a scientifically logical proposal with funding attached to that. So that's in terms of our campus protocol. There are also studies that will be, I think, implemented, and hopefully the IRB for that will be approved soon to study COVID infections, so seroconversion, as well as the types of their, the quantity and quality of their immune response in healthcare workers specifically. And that will be, again, across Children's Hospital Colorado, as well as the adult hospital. Studies that I know that we are sort of involved with consortia. There's a study together with the CDC that is particularly in pediatric population only. And the IRB part is still being worked out here at Children's, but that means that every patient we approach for our campus biobanking protocol will also be approached for that CDC protocol so that we can study COVID in the pediatric population nationwide. And then I am myself involved on a COVID-19 human genetic effort to understand genes that are involved in either that confer particular susceptibility to the infection, so people with no underlying conditions, young, who become severely ill, or potentially the identification of some genes that might provide resistance or protection. And that's what I know.
thanks, everybody. I wanted to ask Bob one final question here. Thanks again to all the panelists and presenters. You studied coronavirus, or you studied viruses, and did you ever think we would be in this situation, having our children wearing masks and being socially divided and social distancing in your career?
No, we have 5 grandchildren, and we're just like everybody else trying to figure out how to social distance and so forth. No, I mean, SARS was a big thing. When it came through, I remember because we got a postdoc from China at the same time, and I went to meet her on the airplane and when she came into Denver, and everybody was kind of frightened. And that time, basically, we worked with Catherine Holmes at the university. She was a coronavirus expert, and so we were able to get funding for that. And we didn't really think it would return. And then we had finished the SARS stuff, and Catherine Holmes went to study bats. And she spent a lot of time looking at Colorado bats for different coronaviruses, which, as you know, is the background for this particular virus. So I didn't know, but I will say good virologists knew that this was going to come back and bite us one way or another. I hope that answers the question, and thanks very much for letting me participate. This is great.
Emily, you're muted again. Emily? Emily, you're muted.
I know. Thank you. Thank you for joining us. Let us know future topics for journal clubs. You can email Jane, Joe Piccioni, Tang Santiago, or me. Thanks for sticking on with us, and we'll see you next time. Thanks to all the panelists, too.
Thanks for having us.
Thanks for putting up with the mute button dysfunction.
Wonderful job, everyone.